A very warm welcome to today's lecture. It's absolutely wonderful to see so many of you here in person, and also to everyone joining us online today. Thank you so much for making it. So today we have the pleasure of a talk from two very esteemed neurosurgeons, Mr. Neil Kitchen and Mr. Patrick Grover. And this is a particularly special lecture because we're marking the time that Mr. Neil Kitchen has been our neurosurgical advisor as he steps back into semi-retirement. I'm not entirely convinced about that. We'll see how that goes. But we're absolutely thrilled that he's going to be staying on as our patron, which is fabulous. So we're going to begin with Mr. Neil Kitchen doing some introductions. Then we're going to pass to Mr. Patrick Grover for the presentation. We've then got a Q&A, and then we're going to follow with a short thank you from our founder, Ian Stewart. He's going to convey his appreciation to Neil and reflect on that time all those years ago when Ian first arm twisted Mr. Kitchen into joining us. So if you're online and you have any questions that you'd like to ask at the Q&A, please WhatsApp them. It is in the registration email. The number's 07872 013522, but look in the instructions, you've got it there as well, so WhatsApp so we can make sure your question is asked. So without further ado, I'm going to hand over to Mr. Neil Kitchen to do a short welcome, and then to Mr. Patrick Grover. Thank you.
Thanks, Sarah. Well, welcome to Patrick and my place, Queen Square, which is a historical part of London, and this is a very historical building that you're in at the moment, the Art Workers Guild. It's at the heart of the arts and crafts movement, and the Guild was founded in 1884, right at that time when that movement was in the ascendancy, and indeed William Morris was the master here in, I think, 1892. And one of their mottos was learning by doing. Learning by doing. And it was all about being hands-on, not delegating, designing, but not in a hypothetical way, designing for a purpose. And although surgery is known as a science, I do think sometimes we do neglect the art and craft of surgery. And there's no doubt about it, by the more you do, the more you learn. And so when you see a clinician, a surgeon, to talk about cavernomas, you need to think, how experienced is this doctor? How many, what is his practice, his or her practice? How specialised are they? And I think that's a really important concept you need to take with you. But although it's very historical here, we also look into the future, and one of the problems William Morris had was he had all these fantastic design ideas, but he couldn't translate it to making wallpaper for the middle classes. He had a big problem with mass production. He couldn't get his ideas out to the masses. And I think that's the same with us. In a sense, we're very good, I hope, most of the time with individual patients, but translating research into change in practice for the majority of patients is much more difficult. So when I started here as a consultant back in '95, there was only 4 consultants here. Now there are 28 consultants or something. So, and indeed, when it comes to dealing with cavernomas, there's probably 4 or 5 of us who practice this type of clinical work. And Patrick is one of our senior consultants in this regard, and I'm very happy that he's going to... so I'm not going to talk today. Patrick's going to give the lecture, but then we're both going to answer any questions you may have afterwards. Patrick, thanks very much.
Great, thank you, Neil. So I've got 2 pointers here. I'm just going to check where. Great. Okay, so hi. So welcome, everyone. So yeah, it's a very good point that Neil makes about cavernoma management. it is very difficult to translate science into change in practice. But I think when I was putting together this talk, it is very interesting how I think cavernoma management specifically at the moment in neurosurgery is one of the areas that is changing, and where some of the research we're doing looking at this patient population is changing our current practice. So I've been through some of the recent data of the patients we manage at Queen Square, looked at some of the trends in practice, and then I'm going to try and link that with some of the wider studies that have been happening in the UK. So, just to get the correct clicker. So just as a bit of background to start off with, so one of the key points of the presentation is that cavernomas are a spectrum, so quite a big spectrum. So a patient coming to clinic with a cavernoma is a very different patient depending on where the cavernoma is, how active the cavernoma is, how large it is. So we can't put all cavernomas in the same basket, and we can't treat them all the same. So in terms of general structure, so in the brain you either have structures above the tentorium or below the tentorium. Above the tentorium is the cerebral cortex, below the tentorium is your brainstem and the cerebellum, so more critical structures perhaps where the neurons are more tightly packed and where the implications of small bleeds from cavernomas can be more significant. And 70% of cavernomas are supratentorial, so in the cortex, 30% are infratentorial, so in and around the brainstem and the cerebellum. They're associated with DVAs in 30%. So DVA stands for developmental venous anomaly, and it's essentially a vein or venous structure in association with the cavernoma, which is a normal part of anatomy, as in it drains normal brain. So a DVA is often a sign that what you're dealing with is a cavernoma, but it's not pathological. It's not something that you want to remove when you're doing an operation. It's often draining normal brain. And you can have a DVA without having a cavernoma, and we will always leave them alone. It's not considered to be something that can cause you harm. Cavernoma is very common. So the other thing that we note in the last few decades is because we do a lot more MRI scans than we used to, we discover that lots and lots and lots of people have cavernomas, which are a completely incidental finding and don't cause any trouble at all. And that number is increasing. So our understanding of how many people in the world actually have cavernomas increases because we do more scans, and we start to realize that the ones that we manage because they're active might be a smaller percentage of the whole. So that's important to understand. For example, if you're a patient coming to clinic with a diagnosis of a cavernoma because you had an unrelated problem, so say you had hearing problems, tinnitus, turns out you have an incidental finding of a cavernoma, that is, again, a different pathology, a different thing to worry about compared to a cavernoma which is presented with symptoms or with a bleed. They're very different diseases, and we manage them differently. You can have genetic forms, so here are the genes CCM1, 2 and 3, more common in Hispanic Americans. And if you've got multiple cavernomas in the brain, you're more likely to have a genetic form, and then often you would go and have genetic testing. These are just some pictures of cavernomas. So you can see, let's go through this with the pointer. So on the top left, MRI scan, and it shows that cavernoma just on the surface of the brain, supratentorial in the cortex. That's the cavernoma there. We say it has a popcorn appearance, so it's dark around the edge and it's bright in the middle. And the dark around the edge is the sort of old blood, the hemosiderin ring. And then the inside of it is the cavernoma itself. And then if you do an operation, it looks a bit like this. So you can see that there's this sort of capsule or the hemosiderin ring, which is dark, and then the center of the cavernoma, which I'll show you the histology slide on the next slide. And typically described as looking like a mulberry, which is an American version of a blackberry, and it essentially looks like that, as you can see in surgery. So go to the next slide. That's what we're looking at inside the cavernoma. So you see these enlarged, sort of closely packed abnormal vessels filled with stagnant blood. So I do other vascular malformations in the brain which are connected with arteries, and the blood is red, and that they bleed a lot when you remove them. With the cavernoma, it doesn't really bleed very much at all. Inside the cavernoma is this sort of old stagnant blood. There's no neuronal tissue within a cavernoma, so that distinguishes it from other vascular lesions, and it's surrounded, as I say, by this hemosiderin ring with gliosis, so some injured brain or a sort of scar on the brain, and then calcification, so sometimes there's some calcium in it as well. Present in many different ways, present with seizures in about 40%, particularly the ones that are supratentorial. Focal neurology, so say that your cavernoma is in the part of the brain that moves your right arm. You might have some weakness in the right arm if the cavernoma were to bleed or be active. Symptomatic bleeding, an incidental finding which is much more common these days, and the main investigation is an MRI scan, and we see them specifically on these sequences, the SWI sequence. So often you might have a cavernoma diagnosed on a standard MRI scan, and then you might go for another MRI scan after that, because we need to do that sequence to see if there's other cavernomas in the brain and to get a bit more diagnostic information. So I'm going to take you through some cases. Now, the reason to do this is to give you an idea of the spectrum of cases, and then to sort of talk more about the research. So this is a lady, she actually worked in the hospital. She just was 25 years old and started to develop headaches and vomiting for 4 weeks. And she had this appearance on the right side of the brain. So initially, this is on the right side, back of the temporal lobe. This is the occipital lobe at the back, which is vision. This is temporal lobe. She had this very large structure here. Look, it's essentially, this is a bleed in the brain. And this is quite a large bleed. And it's unusual, but in the initial phase, we were not sure what this was. Lots of different possibilities. It could have been a tumor, for example. And for her, there's no other treatment options. We would go straight for surgery because it's causing pressure on the brain. She's unwell, she's got headaches, she's got vomiting. This white is swelling in the brain, and this is an acute presentation of a ruptured cavernoma. So took her to theatre, removed that. It turned out to be a cavernoma. There's no residual. That part of the brain goes back to normal. This is a sort of scar on the brain, but all her everything returned to normal. The headaches improved. She's back working in the hospital. So for this kind of case, there's no real decision-making to be made. There's no alternatives. You treat that with an operation, you remove the cavernoma, it's a safe operation, and she does well. So we'll do another case. So this is a 41-year-old right-sided weakness in the arm and leg and face, and some double vision, and also some facial numbness. And this case, again, is another case of a ruptured cavernoma that presents acutely. This gentleman, in his brainstem, has got, again, quite a large clot. And you can see around the clot is this white signal, so swelling around the brain, and he's quite impaired. So again, there's no decision to be made really here. He also then got worse and needed an operation straight away. He had surgery, removed that bleed, and that cavernoma was inside the bleed, and he again made a very good recovery. So he still has some residual double vision, but aside from that, doing extremely well. And again, the cavernoma is gone, so he doesn't need to worry about there being future bleeds. Now, these cases are ones that have presented acutely with a bleed, and that is very different from a patient who will have an incidental cavernoma, which is small and comes to clinic, because obviously that's not necessarily a cavernoma that's going to have a tendency to producing large bleeds like these two cavernomas. So case 3, 21-year-old presents with headaches and double vision when looking upwards. This is not a blood cavernoma, but it's a large cavernoma, but in a difficult part of the brain, and it is symptomatic. Now, for this sort of case, obviously there's a decision to be made. So there's an option of conservative management, but the cavernoma is large and it's becoming symptomatic. The other alternative is surgery to remove it. Now, if we're talking about alternative treatment options, which would be a focused radiation treatment like gamma knife radiosurgery, it's fundamentally too big for that. So there would be no benefit to trying to treat that with radiation, because there's going to be a surrounding radiation to the rest of the brain there. That can cause swelling, that can cause new symptoms, versus if you do surgery successfully and remove the cavernoma, you relieve the mass effect, and again, you reduce the future risk of bleeding. So again, this is another surgical target because of the size, because it's causing symptoms. This is one of Mr. Kitchen's cases, if he's wondering. And so excellent operation, and you can see the whole cavernoma can be removed. This approach is going over the top of the cerebellum to get the cavernoma and remove it in its entirety. And again, that patient will not have to worry long term about bleeds, and also those symptoms improved. I think still some double vision, but otherwise much improved. So surgery is clearly one option for the management of cavernomas, and we conducted a meta-analysis looking at studies in the literature of surgery for cavernomas and their outcomes. So we looked at all the studies in the literature with looking at the patients who had cavernoma surgery, about 70 studies, including 5,000 patients. And if you look at the overall summary statistics, we see about a 4% rate of a poor outcome. So either death from surgery, a bleed after surgery, or a focal neurological deficit. So some new problem after the operation related to where the cavernoma is. That's much higher if it's in the brainstem, so it's 6% if it's in the brainstem, and 2% if it's not in the brainstem, so in the supratentorial compartment, because the nerves or the structures are not quite as tightly knitted together. It's important to remember when you look at this kind of data or these kind of series is that these are obviously people's best series. So if you, people don't tend to publish a series of cases that have not gone very well. So usually in the literature, you'll find people who have very high levels of experience, very good outcomes, and that's what's published. So you couldn't necessarily say for all cavernoma patients operated on in the world that this would be the statistics, probably not be quite as good as this. This is a summary of the best papers. So case 4, we have a 39-year-old lady. She has presented with double vision, right arm and leg numbness and clumsiness, and then the symptoms have resolved. So this is a different beast, and probably more common than the previous cases that I've shown you. So here we've got small cavernoma. You can see this is the brainstem. If we look on this slice, again, this is the brainstem. That's the tentorium. So this is all supratentorial. This is infratentorial. That's the pons of the brainstem. So we've got medulla, pons, midbrain. So it's just at the bottom of the pons, and quite a small area. But because the brainstem is transmitting all the pathways from the brain down to the rest of the body, in that tight space, you can get quite significant symptoms even if the bleed is very small. She's got double vision, their arm and leg symptoms, just because of a very tiny bleed in that location. You can have a very big bleed in this location and not have any of those symptoms. So the symptoms get better. And then I saw her in clinic. So what's the management for a case like this? Well, in broad terms, your treatment options for a cavernoma in that location are either surgery, radiosurgery, or conservative management. And because cavernomas can bleed once and then never bleed again, and because the brainstem is a very difficult location to do operations in, historically the treatment has always been surveillance. So if you have one bleed for a brainstem cavernoma, for the most part, most surgeons would say, well, it may never bleed again, let's sit tight, see if it happens again. If it does happen again, then we may be pushed into needing to do something like an operation. But what has changed, I think, in the last 10, 20 years is that gamma knife radiosurgery does give you another option, and you could consider, well, gamma knife is a less invasive treatment than having a big operation in the brainstem. It's non-invasive, we do it as a day case, and if it successfully reduces your risk of having the second bleed, is that in your benefit versus doing nothing and waiting for the second bleed to happen? And that's really, to my mind, the main question that we've been looking at and trying to answer over the last few years. So, in this case, we opted for surveillance. 9 months later, she does have another bleed. So, this time you can see, so if you compare to the previous one, there's a slightly larger amount of blood around the cavernoma, a bit of swelling, which is this white signal in the brainstem, and she gets a repeat of these symptoms, so the double vision, arm and leg clumsiness, and the numbness. She's still she's still working, she's okay, but you know, we're thinking now we need to do something. There are options for doing operations to remove brainstem cavernomas, but it does depend exactly on where the cavernoma is in the brainstem. And in basic terms, if the cavernoma is here, or on the side, or somewhere that's easily accessible without going through brainstem tissue, then removing it is a good thing to do, and again gives you benefit because the cavernoma is gone and there's no future risk of bleeding. But if the cavernoma is in the middle of the brainstem, you will need to go through quite a lot of normal tissue to get there, and you will probably do more harm than good by trying to do an operation for that. So for me, that's not an option for this lady. So what is the option? So we treated her with gamma knife. So gamma knife radiosurgery is a form of stereotactic radiotherapy delivery, and there are different ways to do that. So gamma knife is one way to do this, which we have the most experience with and we find is the most targeted, but you can also use other modalities, something called cyberknife or fractionated radiotherapy. There are different ways to deliver a high dose of radiation to a very small area, but we do gamma knife, and that's the most common way of doing this in the UK and around the world, and that allows you to give a very focused amount of radiation to a very small area and then deliver very little radiation to the brain surrounding it. So the fall off of the radiation delivery is very steep. And here we can see that is what we do, so that's what we achieve with the gamma knife. The yellow ring is where the radiation is being delivered, and we can really deliver it right in the center of the cavernoma and not to the hemosiderin ring, which we don't actually need to treat. What we need to treat is the cavernoma itself, not the kind of gliosis, hemosiderin around it, because that's not pathological. So that is all we do. It's a small little shot just in the center of the brainstem. These white dots are the frame that are fitted to the patient's head under local anaesthetic, which we need to do for the treatment. So the patient comes in the morning, 7:30 in the morning, has the frame fitted under local anaesthetic, which takes about 10 minutes, 5-10 minutes, then goes in to have an MRI scan. We'll go into the machine, and for something like this, probably only into the gamma knife machine for 20 minutes or 20-30 minutes. Comes out of the machine, we take the frame off, and then they're often home by early afternoon. So it can be quite a quick procedure, and the question is, how effective is this? So we know that we can do this, and we know we can do it pretty safely, but is it actually effective in reducing the future risk of bleeds? So she has follow-up 3 years later, 18 months. She did have one further episode of pins and needles in the foot. We did a scan, it looked the same. Since then, she's had no more episodes. So you think, well, she had 2 bleeds before she had the treatment. Then she had the treatment, she had no more bleeds. So probably the treatment worked. But the reason why we can't just say that is because she may never have had another bleed. So the bleeds from cavernomas can cluster. And we know that if we just follow cavernomas up and never treat them, lots of patients might have 1 bleed or even 2 bleeds and then never have a bleed again. And we don't know if that was because of the treatment or she would never have had another bleed anyway. So what we need to do is look at the statistics. So this is a meta-analysis looking at all cases of cavernomas that are followed up and their bleed rates. And it shows us, in broad terms, these are the percentage risks of having another bleed from a cavernoma. So if we go by category around this red box, so if you have a cavernoma in the supratentorial compartment which has never bled, your risk of bleeding at 5 years is about 4%, so just under 1% a year. If you have one in the brainstem which has never bled, your risk of having a bleed in 5 years is about 8%. If you have a cavernoma supratentorial compartment which has bled, then your risk of having another bleed in the next 5 years is about 18%. And if you have a cavernoma in the brainstem that has bled, your risk of having another bleed in 5 years is 30%. So as you can see, very different, you're dealing with very different things depending on where they are. Now this is a meta-analysis of stereotactic radiosurgery techniques for brainstem cavernomas, and it looks at 570 odd patients, and it shows, we think, that the hemorrhage rate decreases significantly between 0 to 2 years and more than 2 years if you have gamma knife or another form of radiation delivery for brainstem cavernomas. The cavernoma can reduce in size in about half of cases. The risk of side effects or complications is low. So radiation edema means swelling where you deliver the radiation. That's 7%, and this is in the brainstem, and that's symptomatic radiation swelling. So you might have some new symptoms, but then the swelling goes down again, and then long-term you're okay. Or it could be permanent. So in 2%, you might have some permanent new symptoms secondary to the radiation delivery, which causes you long-term problem. And the majority of studies show that the symptoms are either stable or improved after SRS. So this is very positive. What's our experience? So at Queen's Square, I look back through our sort of recent cases over the last 7 or 8 years. We've treated 36 patients with gamma knife. The median dose is 13 gray, so it's all pretty standardized treatment. What's important is the treatment volume is 0.2 cc's, so we're treating small cavernomas. So we can't say that this is representative of our treatment for all cavernomas. So this is mostly the small ones like the lady that I've shown. And on average, the patients had 2 prior symptomatic bleeds, but we have treated 13 after 0 or 1 bleed. So we can treat earlier, and we do treat earlier in the right circumstance and with the right counselling. The follow-up, on average, about 2.5 years. So a lot of these patients that I've reviewed have actually been treated in the last 1 or 2 years. So we can only say so much about how effective it's been. And of these, we've had 1 case of symptomatic radiation edema, and we've had no bleeds after treatment. So we're doing this more. And if we look at the trends in treatment, and just to say that, to give you an idea of the landscape, there are 2 centres in the UK that do gamma knife for cavernomas. There's Queen's Square and there are Sheffield. Sheffield have done more than we have done and have been doing it for a longer period of time, but they also have similar data that they're positive about. And at Queen's Square, this is the increase in our numbers. So we've been doing 1 or 2 a year initially, 2014, 2015, and then now, 2024, we've done 11 cases in 1 year. So we're clearly increasing the number of cases we're treating. It may partly be because we're getting more referrals, but also because we're pushing to treat these a bit earlier. And maybe, I don't know, but maybe patients that would have had surgery are now having gamma knife. So if we look at surveillance, now we've also looked at this. This is a question from the it's actually in association with the Cavernoma Alliance and the James Lind Alliance, looking at the questions that cavernoma patients would like to know the answers to. And one of those questions is, does regular monitoring of brain or spine cavernoma improve outcome compared to no monitoring? So we've reviewed 133 patients treated with cavernomas at Queen's Square between this 8-year period. So this is actually before you've seen that increase in the patients who are getting gamma knife. And if we look at the ones that in this cohort, about 40% presenting with hemorrhages, 40% with headaches and focal deficits, and 16% incidental. Now, that number, you can see, is not reflective of the true number of incidental cases. So we will be following up a lot more incidental cases than that, but we don't have the data for them because there have been lots of different clinics and under neurologists that we have not captured the data for. So it's easier to capture the data for patients that you've treated. And these are some of the data for those cases. So over that 8-year period, 133 cavernomas, about 50 were treated with surgery, 7 at that stage had radiosurgery. That number is much more now. And 77 treated conservatively, so with initial surveillance. Now, the other thing to look at is the volume. So you see these volumes now are larger, so that's more reflective of the general volume for cavernomas, but again, it's slightly skewed because these are mostly the ones that we've treated. But you can see this volume is significantly higher than the 0.2 cc's for the ones that are having gamma knife at the moment. So larger cavernomas is not so easy to treat with gamma knife, and a lot of those will end up having surgery. The other thing is that, here's the next slide, there's a lot more of these cases which are supratentorial. So the majority of the ones that we're treating with gamma knife are in the brainstem or very difficult to access places. But for these cases, there's more than 50% are supratentorial, 22% in the brainstem. So slightly different results there. Now, if we look at surveillance, so patients followed up for a mean of about 60 months or so. During the surveillance period, so of those 77 patients that were undergoing monitoring, 16 had a bleed. So our bleed rate for those being surveyed is about 2 per 100 patient years. The other question is, are we benefiting? Is there a need for us to be doing this surveillance? And we found that there were 8 cases where routine clinic review or an MRI scan resulted in a change of management. In terms of surveillance, again, the main question really is, what are you dealing with? So most, as I say, the incidental asymptomatic cavernoma is a very common finding on an MRI scan done for other reasons. And you would never ever treat that unless it became active and caused symptoms. So it's not necessary to do an MRI scan every year for a cavernoma that's not causing any trouble and not causing any symptoms. Because at the end of the day, you're not going to do anything about that MRI scan. The only time you would do something is if you started to get symptoms. So many of those patients will come to clinic, you will say, well, this thing has just been found incidentally, it's not causing any symptoms, so we won't do anything, and I wouldn't recommend any follow-up. But if you do have symptoms, particularly X, Y, and Z, related to the area where the cavernoma is, then come back, and then we will do an MRI scan, and if something has happened, we can talk about things. And the vast majority of those patients you don't see again. And that's why the denominator for this data I've showed you is not quite reflective. A lot of these patients in the community not having follow-up, not having further scans, completely well. Now the CARE trial, many of you will be aware of this or maybe have been involved in it. This is a randomized trial that was looking at comparing surveillance, gamma knife or stereotactic radiosurgery treatments and surgery for cavernomas. And it was essentially a proof of principle trial looking to see if we could conduct a randomized trial to compare these different management strategies and see which one might be best for those specific patients where all those options are available. So for many patients, so some of the patients I showed you at the beginning, all those options are not available. If you have a big bleed from a cavernoma, you don't have a choice between surveillance and surgery. You need to have the operation because of the effects of the bleed. So this is just looking at the ones where you have equipoise. And the way it was structured, slightly complicated compared to a lot of studies that randomized controlled trials you may have seen, but essentially at the beginning you decide if you think this cavernoma might be better treated with an operation or with stereotactic radiosurgery or both. And then, if once you've decided that, which is usually in an MDT, you go into one arm or the other, and then you randomize to having either that intervention or surveillance, and then on both of those arms you compare either surgery versus surveillance or radiosurgery versus surveillance. This is the recruitment, so almost all the centres in the country, almost all the major neurosurgical units in the country were enrolling patients, so that was very successful. In terms of recruitment, that was less successful, particularly at the beginning, and it was unfortunately hit by the tail end of COVID, so that meant that getting the centres up and running took longer than expected. And the predicted recruitment is this line, and the actual recruitment ended up being this line. So recruitment was quite a lot slower than it was hoped for initially. And then towards the end, as everyone sort of got familiar with this, we had a big uptick and then achieved the stated goal, which was 60 patients in that time frame. So I screened quite a few patients for this. I had quite a lot of consultations, and as you might imagine, it is difficult when you have a consultation to say that we don't really know what's best for you, and we're going to randomise you in a trial, and then the trial will decide what to do. And you can have a lot of consultations where, obviously, for the cavernoma community, it's really important for us to run trials like this so we do know what is best for patients. But for each individual patient, they may say, well, I'm supportive of the trial, but I personally don't want to be randomised. So for all the patients we screened, 500 patients across the UK, we randomised 72. And remember that those 500 are already the ones that we've pre-decided are suitable for enrolment in the trial. So there are patients who people would not even have entered into the screening log to say that we've considered the trial. And the other thing we did was we recorded the consultations. So this was new for me, but essentially to see why patients may or may not be recruited, the consultations were recorded, and we got feedback on how you conduct a consultation for Cavernoma and how that may have affected the recruitment by centre. These are the two patients that we recruited at Queen Square. And this patient, 42-year-old, both of them were recruited and enrolled for gamma knife. This patient had the treatment, very similar to the previous case I showed you, so a small cavernoma in the pons, which had presented with a bleed. And this patient, who was randomized to treatment for this cavernoma, but then changed her mind and decided she didn't want the treatment after being randomized. So you'll see, but she still would be counted in the overall statistical analysis, but she was randomized to treatment, but actually then didn't have the treatment. And these are the results. So, for patients so we essentially randomized 36 patients to surveillance, and medical management means surveillance imaging, 24 patients radiosurgery, 12 patients to surgery. And you can tell that this is small numbers. The numbers in brackets are the patients who actually had the treatment. So 12 patients randomized to surgery, but 9 patients actually had surgery. 24 patients randomized to radiosurgery, 20 actually had radiosurgery. The primary clinical outcome was either a bleed or some focal neurological deficit, and that happened twice in the patients who had no treatment at all. So we presume that would be a bleed from an untreated cavernoma or some sort of activity in the cavernoma. In the radiosurgery arm, no patients over the follow-up period, which is 6 months, had any episodes. And then for the patients who had surgery, 2 patients had some new problems, so focal neurological deficit or maybe a bleed, but we don't know, it's not published in the paper. So as you can see, small numbers, not statistically significant. If you compare intervention overall compared to surveillance, you've got it's the same. So it's 2 events versus 2 events, comparing both of those arms. And this is the duration of follow-up and when those events occurred. So it's a pilot study. It was a lot of work for that data. And the question is, can we get to a point where we enroll sufficient patients where we have statistical significance? And that is really what Professor Al-Shahi and the Cavernoma group are looking at. Is it going to be possible to roll this out as a larger study? And I think it will be difficult. We have obtained some feedback from the BMVG, the British Neurovascular Group, and the surgeons who have enrolled patients. In general terms, if we look at these numbers, so using different predictors, the rate of surgical complications, for example, or post-gamma knife complications, and doing a power calculation, a definitive trial would require somewhere between 590 and 1,900 participants. So we can't do that in the UK. That would have to be an international study with a lot of buy-in from a lot of centres to come to a statistically positive outcome. And I think that might be possible if we did this specifically with stereotactic radiosurgery, but I think including the patients who had surgery as well, that would be much more difficult. Just looking at how hard it is to recruit patients to say, I'm going to randomise you to having an operation or not. And that was it. No more to say. Any questions at all?
I just want to say a massive thank you to Mr. Patrick Grover. I have heard a lot of lectures on Cavernoma, and every time I learn something new, which I did again today. So thank you. Another round of applause. So we've had a lot of questions come in already on the chat, which is amazing. So what I'm going to suggest is we alternate between questions in the room and questions online. I'm going to call upon Tracy to help me with the roaming mic. Is that all right, Tracy? If you can do those in the room. And then, Neil, if you want to come up as well. And then what I'll do is I'll read the question out if it's online, and then pass over, and then for those in the room we'll take. So I think, Tracy, why don't we begin with a question in the room, and the mic's just down there, and it's the one, there's the little green light. So I think we've got our first. It is, yeah. So Tracy, I think it's Cindy just there at the front has a question.
Can you hear that? Oh,
can.
Perfect. Testing. So
Who was that? Oh, Cindy.
Have there been any studies about lifestyle changes to prevent an incidental cavernoma from bleeding?
The answer to that is no. There's a lot of discussion amongst cavernoma groups, about the patient groups anyway, about that aspect. I only tell patients to avoid anything I say to avoid is anything that raises the blood pressure very significantly, very quickly. And so that might be the only thing that would be conceivable would be some sort of recreational drug or something like that, which occasionally people take. So I say avoid anything like that, but otherwise you can do as you wish. That's my view.
Yeah, it's basically extremely difficult to do any studies on lifestyle changes with any pathology, because, say for example, you are looking at recreational drug use, people have to report that they're actually doing that, which is often not the case. You would have to do a study where you followed up thousands and thousands of cavernomas and then identified people that did something quite unusual, like deep sea diving, and then prove that those patients had a higher risk of bleeds. But you can do this for. There are studies in other pathologies where you can do that for, say, if the patient's taking aspirin or not, and then show that those patients do have more bleeds. But for more other things like exercise or things that are quite difficult to characterise, it's just not really feasible to do that kind of study. Well, again, stress. How do you measure stress? So you could use blood pressure as a surrogate for stress, and then you could say, well, maybe these patients have more stress and their blood pressure is high and therefore they're bleeding. But even with blood pressure, I think there's uncertainty there, because if you do an angiogram on a patient with a cavernoma, so if you look at all the blood going in and out, there isn't arterial blood going into a cavernoma. So you wouldn't actually think that if the blood pressure went very high, it would necessarily cause a high risk of a bleed. But we do say, if I were you, I probably wouldn't take that risk.
Anecdotally, people with vascular disorders in the brain, cavernomas, AVMs, which is another type, or even aneurysms is the typical one. People say, well, I was having a big argument with my wife or my husband or whatever, or I was at a car crash, or, and then this happened. But equally, people say, well, actually, I was just watching TV, or I was, and I do think, my personal view is that it's not related to, I personally think stress is relevant, but not in the acute thing. I think it's a cumulative stress that is a factor, personally. That's my own view.
I'm sure you've seen a lot of patients with cavernoma, and there must be that similarity between all these patients. That there is perhaps
not always, but I find that is a frequent thing. I would say.
Lovely, thank you very much, Cindy. It's a good question and good answers. So we're going to have a question now online, and I'll try and get through as many as possible. So this was our first question. I have a cavernoma that's caused me significant problems in my life for more than 3 years. It's bled each year to 2021 to 2023. Recovery is slow and difficult, and I've got a reduced quality of life. I've had stereotactic radiosurgery in 23, and unfortunately it didn't help, and I went on to have another bleed. And the consultants have advised no further help will benefit me because of where the cavernoma is. It's located in the thalamic region. What I want to know is there no further help in the UK or elsewhere for a patient with a cavernoma in my location?
Well, it's a difficult question to answer because we don't have the scans and so on, and to comment on an individual case. But what I would say that if you see, radiosurgery, radiation, it's not like an operation. If an operation, you take the thing out completely and then the bleed risk is finished. With stereotactic radiosurgery, it doesn't work immediately. It takes time to have its effect. But if she's had a bleed, if the patient's had a bleed, what is it, a year or so after the treatment, then it hasn't worked at that point. And we know I don't think that radiosurgery eliminates the bleed risk completely, but we feel, our experience, and as Patrick has shown, it does reduce that risk. But of course, our follow-ups are very short at the moment. There's no other treatment apart from radiation, which hasn't worked here, or an operation. And so one would have to look at the case. I can't really comment any further than that. So unfortunately, some cavernomas are not safely removable. That's it.
Thank you very much. And now to the floor. So I think we've got a question at the back there. Carol, what's your question?
How is research into cavernomas progressing into ones on the spinal cord? Closer. How is the research and knowledge into cavernomas progressing into knowledge on the ones in the spinal cord?
Oh.
Spinal cord was only mentioned once, and there was no case studies of ones with spinal cords.
Excellent. And just to add, actually, we've also had a question on that online, just about spinal cavernomas. Just for those in the room and those watching, we had an excellent webinar by Mr. Daniel Walsh on spinal cavernoma, and that's on our YouTube channel. So if you want a really in-depth lecture on spinal cavernomas, go to our YouTube channel, and there's a really good one there. But let me hand over to Mr. Kitchen and Mr. Grover just to talk about what we know from the latest research about spinal cavernomas.
It's a much rarer entity. So in my practice, certainly, I've got very few patients with spinal cavernomas, or particularly active cavernomas. And you can see that the numbers for the CARE trial are already very small to do sort of major studies, and particularly on comparing interventions. And so for spinal cavernomas, there's very little that I'm aware of in terms of current trials for that reason. Also, at Queen Square, we do gamma knife, which is very effective for cavernomas in the brain, but you can't do gamma knife for cavernomas in the rest of the body because the frame is fitted to the head and the rest of the body is mobile. So those patients will be treated with other treatments like cyber knife, for example, or surgery. But I think as it's a much smaller cohort, I don't think there is very many sort of current trials at the moment that I'm aware of, unless Neil's aware of them.
No, there's not. And I think when you think about it, cavernomas occur anywhere in the central nervous system, and that's including the brain and the spinal cord. But in volume, the spinal cord is tiny compared with the brain. So that's the way I look at it anyway. So spinal cord cavernomas are rare. There's no doubt about it. And you could say, well, and even when because people have spine MRs all the time for back pain or neck pain, or whatever. And you thought if they're quite common, but incidentally, we would see a lot of them. Everybody would see them, but we'd see them very, very, very unusually. So I think that's the issue. It's the rarity.
Carol, thank you for your question. Just to say, as a patient advocacy group, whenever we're approached to discuss research, we always advocate for the inclusion of brain and spinal cavernoma. One of the challenges we have, though, as been discussed here, because it's so rare, to really get good results, you have to have a certain number, and there's a real tension there. But just want you to know we care about spinal cavernoma research, and we will keep flagging that with researchers. So I've got another question here online. I have 31 cavernoma on the brain and 2 in the spine, and I've now been diagnosed with ME and POTS. And this person is not being offered surgery, and they're just wondering why, given these new health conditions.
So, if a patient has a single cavernoma, in a way it's easier as a doctor, in a way it's more difficult. If you have multiple cavernomas, actually it may be more difficult for the patient, but for me it's easier because you can't possibly do 31 operations, right? So I say to those patients, let's just see what happens. the vast majority of those cavernomas will not do anything at all. They might be tiny, very tiny things. Some of them might disappear, and we want to just deal with a particular cavernoma which might be bigger than the rest or might have bled, and so it's in a way I'm much more conservative with patients who have multiple cavernomas. This is surgically. I'm not talking about drug therapy for seizures or something like that. I'm talking about intervention. Whereas, and I think that patients understand that. Whereas with someone who has a single cavernoma, quite often it's a kind of the reverse. The patients kind of might have a lot of symptoms, all of which they think are related to the cavernoma, and it's trying to disentangle which ones actually are and which are not. For example, headache is a very common symptom which my cavernoما patients have, and indeed a couple of patients who have shown no signs of bleeding at all we have actually treated because they're so anxious about their cavernomas and how they're causing headaches. They believe they're causing headaches all the time that it was affecting their health, and so we've ended up treating them. But clearly this particular patient has multiple cavernomas and she has ME and POTS, so she's got a lot of other things going on as well. But they're not related. So it's a different. I think they're two different issues. Yeah.
Cindy, just for people who are joining online, do you mind if we give you the mic, just so we can make sure it's captured?
I would argue that it is related because the stress of having a cavernoma can cause stressful psychosocial events such as ME and POTS. So I would argue that it is related, yeah.
Thank you. So just to say, for people online, I'm so sorry I've had so many questions come in, and looking at the time, I'm not going to be able to take new questions. So I have seen your messages come online. What I will do, though, is pass these over to our helpline, and we'll try and come back to you in the next week or so with an answer. So we're going to take another question in the room.
You said the genetic form that is common in the Hispanic Americans. I just want to know, the CARE study, how many black ethnic people did you have there? Because this experience has happened to me 4 months ago, and everywhere I've gone for meetings and all, I'm always an outlier. So I'm wondering, in the study, were there any black ethnic people with cavernoma?
I don't know.
It will be on the demographic data, but we'll have to find it out.
Yeah, I'm sorry. I'm afraid I don't know the answer to that question. We'd need to look at the.
There is a demographic table in this paper which we will look at.
Yeah, I'm sorry. I don't know the answer to that, but yeah. It's not. I mean, if studies like this already we're talking very very small numbers. So if we do subgroup analysis according to ethnic background, I would have sure there would be no data coming out of that that's useful.
Yeah, I mean, you're not allowed to do post hoc analysis anyway, so there's no subgroups, but there will be a table about patient age, sex, ethnicity. We'll look it up.
Yeah, and I'd just say I do remember looking at that data with Professor Rastam Al-Shahi Salman, who ran the CARE study. So I know we've got the data, and we just need to check on the answer to that. But I think you make an important point about inclusion, and patient advocacy groups tend to be white middle-aged women is the demographic, which is kind of what's here. And as a charity, we're actually meeting with our Board of Trustees tomorrow to talk about our 5-year strategy, and we've identified that as an issue because this condition doesn't overly represent white middle-aged women, but those are the people coming to the meetings and engaging with us. So we want to do something about that, and that needs to be sincere, not tokenistic, so we're going to work that into our 5-year strategy. So thank you for raising that. It's really important. So I'm going to go to another question now online. So I've been told I have an occipital cavernoma, and that if I have a head injury, I will go blind. And I want to know anything about it. And then they've added to say, I've been getting pins and needles in my arms. Could this be connected? I have had a bleed in the past, and they also have a DVA at the top of the brain area. So So this is quite a rare presentation, isn't it? Or fairly rare? Or maybe I've got that wrong.
Yes, I mean, so if it's on the occipital lobe, then pins and needles in the arms and legs probably won't be related to the cavernoma, depending on, unless there may be other cavernomas in the brain. But the occipital lobe mostly relates to vision and the visual pathways. So if cavernoma is active and there are associated visual symptoms, that could be associated. Headaches, for example, yes, that may well be related, but we always have to remember that there are other causes for headaches, which might not be cavernoma related. But if a patient has a headache and then has a scan that shows a bleed, probably it is related to the cavernoma. And in the occipital lobe, we describe it as an eloquent part of the brain. So it is an area where there are parts that, if it was superficial, it could be amenable to surgery, but if it's quite deep in the occipital lobe, you may often be better off certainly not having an operation, because there's a risk that could cause you a vision problem you don't currently have. And then we're into the situation of thinking, should we consider gamma knife? Because gamma knife would be less likely to cause any damage to the surrounding tissue and might reduce the risk of further bleed. The interesting thing about that case is, a point I didn't quite bring up in the presentation, is that one thing that is changing in and around the CARE trial is this concept that we should be treating patients, or should we consider treating patients a bit earlier after one bleed rather than waiting for the second bleed. So that might be a conversation to be had.
And Mr. Kitchen, anything on that worry about blindness from head injury?
Well, the head injury thing is an interesting topic, because people with cavernoma say, well, can I do contact sports, or what happens if I bang my head? Is it going to cause? So there has been there's been a few case reports of patients who had an underlying cavernoma and were assaulted or something and had a brain bleed. Now, it's very difficult to disentangle this, and I've seen patients who are rugby players and boxers who've had a scan, they've got a cavernoma, they can't box anymore. And I had a rugby player who had a cavernoma which had bled previously, but it or rather it bled, but he hadn't noticed it. It was asymptomatic, or he denied having any symptoms from it. And he came with his club doctor. His club doctor said, what was there with him? He said, well, no, we want him still to play. I said, well, it's not. I personally don't think it must be a very great increased risk, but if you did have a collapse on the rugby field, then people worry about you and so on, so you really can't play. So okay, they went away not particularly happy with this, as lots of sportsmen are when you tell them, women who's saying you can't do what they want to do, they basically ignore you usually. And so this guy then disappeared, and then I next heard the same club doctor came with another player about something else, and I said, what's happened to this chap? He said, oh, he's playing sevens rugby in Hong Kong. Just completely disregarded what we said and carried on playing rugby. So clearly, if you've got a cavernoma, but I think it would have to be not these tiny little things we're talking about, but say it was a large cavernoma which was acting like, inverted commas, a tumour, so a space-occupying object in the brain, and you had a significant head injury, you'd think there might be an increased risk of having a bleed from that. I think common sense would say that.
Thank you. So just for times, I think we can only take 2 more in the room and then 2 more online. Tracy, you're going to have to work out who put their hands up first. I'm sorry. So in the room, over to you.
So I was just going to ask, with the gamma knife treatment, I noticed for the genetic patients, you didn't really have many who'd had the gamma knife. And I heard that somewhere that radiation may trigger more cavernomas to grow in the genetic versions. Is that the case?
Well, I mean, yes, you're right. There is that concern. I mean, we also have a cohort of patients who have had radiation-induced cavernomas. So again, that is a group of patients where you think, should we be delivering a radiation treatment? But equally, if you have genetic cavernoma syndromes and you have 31 cavernomas in the brain, one of them is bleeding repeatedly and it's not accessible to surgery, then we would still treat that with gamma knife, but on the understanding that there may be a slightly increased risk from that.
Yeah, I don't think there's any evidence that it causes more cavernomas to grow. It's a very very focal treatment, gamma knife. So it should be considered like a surgical treatment. So radiation-induced cavernomas are usually patients who in childhood many years ago have had whole brain radiotherapy, in fact whole brain and spine radiotherapy for cancer, which is much lower dose.
Thank you.
Thank you. So I'm just going to take one online now. So I'm 37 and I recently had a hemorrhage from a brainstem midbrain cavernoma. I've got mainly side numbness and it's improved, but I'm still symptomatic. And I want to start a family. And I'm wondering if there is a time you should wait before falling pregnant after a bleed. And then should I think about gamma knife before falling pregnant or just gamma knife in general? And then they've also asked a question about hormone therapy and IVF. Just on hormone therapy, there's a page on our website which we've written based on a recent study about HRT and oral contraception. So if you're got a question about this, do go have a look there. But I'll just hand over for the answers to the other questions.
Well, this is it's a difficult scenario. One question that's often asked is, does pregnancy increase the risk of a bleed from a cavernoma or any vascular malformation in the brain? And again, similar to the previous questions we've answered on this, there's not strong evidence for that, but you may say with blood pressure changes in pregnancy and with childbirth, you could have a slightly increased risk of having another bleed. So that's one thing to take into consideration. So then, if the lady's 37 and she's thinking of starting a family soon, if the cavernoma is amenable to treatment with radiosurgery, and we did that before pregnancy, the effect might be beneficial within sort of 6 to 12 months, so that might be a good thing to do. Equally, based on the previous practice of might never bleed again, there is still the option of just not having it treated and going ahead with pregnancy, and then it may not bleed again, and you also may not have the potential side effects of the treatment.
I mean, it is a tricky but common enough scenario, because obviously cavernomas occur in females of childbearing age very frequently, and you'd have to take every individual as it is. But I think that put it this way, being pregnant is not going to decrease the risk of having a hemorrhage. It may not be significantly raised, it may be just the same, but you've still got that aliquot of time, what's 9 months when okay, you know, no one likes doing a scan when a patient is pregnant at all, so that's a hassle, but you can often get it done if it's an emergency. But it's not that really, it's the fact that if you did have a bleed during pregnancy, it could be a big problem if then you needed to have an operation, for example. So that, you know, it's a value judgment about your health and about having a family and so on.
So I do have a patient I operated on the year before last, who's a guy, but his wife is pregnant, and we talked a lot about, he had a bleed from his cavernoma, and we talked a lot about when is the best time to have the operation. So he decided he was going to have the operation, but he didn't want to have it when his wife was in the end stages of pregnancy. But then when we discussed that also having treatment for a cavernoma or surgery with a young baby is also a very difficult, stressful thing to go through. So in the end, we actually did the operation about 4 weeks, or not very long before she delivered. And then it went very well, and he was then very happy. He didn't have any more bleeds. He came off his anti-epileptic medication, and then amongst my happiest patients. But, you know, every situation is different.
I'm so glad I'm not a neurosurgeon and have to make these difficult decisions. And just on IVF, just to flag, so there is the option for pre-implantation screening. In the UK, that's licensed for CCM1 and CCM3, and there's currently a consultation underway for CCM2. So I'm ever so sorry, it's one more question in the room, one online, and then we're going to have to wrap up.
Is that working? Yeah, okay. Thank you so much. That was really helpful. I saw an article that was early published results of a drug trial in the US to potentially treat cavernomas. Have you got any comments on that, or how that's progressing as another treatment option?
So just in terms of drug trials in the US, there's various trials at the moment. So some of the drugs, REC 994 is one. You've also got ROC inhibitors. There's also trials on repurposed medications like propranolol, atorvastatin, aspirin. And we're really interested in finding out more. All of those, though, are not yet at the stage where there's been enough trials to be undertaken for them to be considered for license or commissioning. But there's quite a few. A really good place to go is the Alliance to Cure website. And on that website, there's a tab titled Research. And if you click there, they have a fabulous graphic, and it shows you every single medication they're looking at and where they're at in the trial. And then you can click through. So I'd say have a look there, and it's exciting. You know, we're really hopeful that we're going to have some non-surgical options in the future, but it is still a bit of a way.
I think that's right. I think it is an exciting area. I think it's more exciting than the surgical side, actually, because I think there will be some. I think something will genuinely come out of it. But it's. I think one of Professor Al-Shahi's thoughts is also not whether we're going to do a bigger trial looking at the same thing in the pilot study, or do something separate or combined, having a sort of a trial where there could be a menu of taking different trial tablets as well. So it is. I think it's an exciting area, but we've just got to wait and see.
Thank you. So just the last question online, and I'm so sorry for everyone who hasn't had a chance to ask a question. I don't know whether Mr. Kitchen and Mr. Grover are going to stay for a few minutes afterwards for coffee, so maybe sidle up. You might go, sorry. So the last online question, first of all, someone's saying, what an amazing lecture, I'd agree. Unfortunately, I have a brainstem cavernoma that's bled and caused symptoms after surgery and gamma knife. But I haven't had symptoms now for 10 years. Are there stats on the chances of a future bleed and symptoms?
Well, 10 years is a long time, so I think in terms of very long cohort studies that we don't have that level of data. But the one area I'm quite interested in is conditional probability modelling. So I think the issue we have with a lot of vascular studies and vascular trials, like the data I was showing you, is that we have evidence for 6 months or 1 year or maybe 5 years after treatment. But what you're interested in is what is the benefit to you in your lifetime. And so should I have these interventions now, which gives me that benefit for the rest of my life, compared to if I did not have a treatment for my whole life. And conditional probability modelling is a way of looking at the data if you follow up patients for X amount of time, and then for the number of years of follow-up, giving you a percentage risk of something happening. And what it looks like if we do this, for example, in aneurysms, so if we have an unruptured aneurysm that we follow up for 5 years and nothing happens, the chance of something happening is much lower there compared to if you followed it, compared to sort of 1 or 2 years after diagnosis. And similarly with cavernomas, I'm sure we will find the same sort of thing. So that is a work in progress. I have some people at Queen Square who are very good at this kind of statistics, and I think if we can get data, for example, follow-up from the CARE trial or other larger cohorts, then we could do conditional probability modelling and then give you a better idea that after 10 years, your risk of having any future event is very small. I
echo that completely, and one of the things I've thought of over the years is how can we predict whether a cavernoma in a particular patient is going to be quiescent and do nothing for years and years and years and be in that sort of benign group, let's call them, and how do we pick the minority who are going to be playing up and causing problems? And I still haven't figured it out yet.
Well, thank you so much. I think we gave them some quite tricky questions, didn't we? So a big round of applause for answering so well. So we've just got 5 more minutes, and that's going to be me handing over to Dr. Ian Stewart, our founder. It's nearly, in 2025, it'll be 20 years since the charity was founded by Ian. And one of the things Ian did at the beginning was basically persuade Mr. Neil Kitchen to be our advisor and patron. And as Mr. Neil Kitchen steps back from being our neurosurgical lead advisor but remains as a patron, we wanted to say thank you. So Ian, I'm going to hand over to you now to give you that speech.
Thank you, Helen. I want to begin by craving Mr. Kitchen's indulgence and thanking 3 or 4 people who are connected with my original founding of this organization. I have to say my speech is such that I don't do public speaking anymore, but I did, when Helen asked me to agree on the basis that I was saying goodbye to Mr. Kitchen and his inestimable contribution to Cavernoma. But I want to thank, first of all, I'm sure our thanks go to Mr. Grover for discussing Cavernoma so well, and to the Board of Trustees, which obviously dotted around the room wearing T-shirts, and to Tracy, who represents the staff. And most important of all, please will you join me in thanking somebody who's very good at thanking people for their contribution, but to my knowledge hasn't been publicly thanked, and that's Helen. So thank you. Mr. Kitchen was, or is, a dedicated professional who has advised many of our members, in fact, saved many of our members' lives, including my own, through not doing anything. And this, I know because Mr. Kitchen was saying to me just beforehand, it's very difficult to know when not to do anything. And so I wanted to congratulate you for that, and also say something about you have supported Cavernoma Alliance UK from its beginnings to present day. You've done London Marathon in 2009 to generate funds for us. You've done the CARE trial recently for us. And I remember one member telling me that your bedside manner was exceptional, and how you came to her and sat on bed and said, well, I'm fully prepared to do this operation, but it's up to you whether you go ahead. And I think that that sort of confidence and that sort of desire to do an operation, but knowing that the patient is always behind the reality of that operation is so important. I also, in this regard, and to crave your indulgence again, I want to thank Professor David White, who our recently retired scientific advisor, who with his wife Pat Spallone has been very at the forefront of doing things on fertility. I should have thanked them earlier. But forgive me for my audaciousness, but I will say this, that 20 years ago when I founded Cavernoma Alliance, I'd come to you as a patient in 2002, I think it was. And this now sinks into my mind and has gone through various permutations, and maybe it's not true, but this is how I remember it, that you took me into the consulting room and you sat down and you were discussing with me the various options. I just arrived back from the US where they're very keen on doing surgery. And in fact, I was in the room of one neurosurgeon who says, well, we'll have a go on your brainstem cavernoma. And I thought, well, not having a go on mine. And so I then became conscious, sitting in your consulting room, of one aspect of you which I will remember through my life, and I don't know, no, you're not today, but you were, and forgive me for saying this, but you had on you some red and yellow socks. And I remember thinking, well, I know this is audacious and frivolous and impudent to say, but I remember those red and yellow socks. So I know that Helen has got for you a very nice trophy on the celebration. I got from Dawson a pair of socks. What I remember.
That's like a drop mic moment, isn't it? What a lovely way to finish today's lecture. I just want to say a massive thank you to our speakers, Mr. Patrick Grover, Mr. Neil Kitchen, to a wonderful thank you from Ian Stewart, to all the staff, to Tracy, our volunteer manager, who's been doing the roam mic, also to our trustees who came today, Barbara, and to Roxana. We've also got a representative from our advisory board with Charlotte here, and many volunteers as well, Francis, many others here. It's just been so wonderful to have you here today. Massive thank you. Big thank you to everyone who's also joined us online. And if for any reason you've had to dip out, you've missed some of it, don't worry, it's been recorded. Within the next couple of months, we'll get it up on YouTube so you can re-watch it. So thank you ever so much, everybody.